I'm Dr. Richard Bogan, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 3 of the four-part CME OCAS series, Fine-Tuning Diagnosis and Management of EDS in Patients with Narcolepsy and Obstructive Sleep Apnea. Today's episode is titled Differentiators when Choosing Treatment Options for EDS. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Again, I am Dr. Richard Bogan, president of Bogan Sleep Consultants, medical officer of SleepMed Incorporated, and director of SleepMed of South Carolina. I am also the associate clinical professor at the University of South Carolina School of Medicine in Columbia, South Carolina, and associate clinical professor at the Medical University of South Carolina in Charleston, South Carolina. I'm very pleased to be joined today by a national and international expert, Yves Davier. He's professor of neurology and physiology at the University of Montpellier and director of the Sleep-Wake Disorders Center, Department of Neurology in Montpellier, France. Welcome, Yves.
Thanks, Rick.
So, to frame today's episode, let's start by reviewing our learning objective, which is to apply efficacy and safety data to treatment decisions for EDS in patients with obstructive sleep apnea or narcolepsy to improve quality of life and functioning. Of course, narcolepsy patients are profoundly sleepy and give us some insight into sleep-wake processes because of the pathology. And obstructive sleep apnea patients are profoundly sleepy. The majority of them are, and it's one of the most prevalent disorders that we see in the sleep clinic, right along with insomnia. But it's a prevalent disorder, and many of the patients still have sleepiness despite our best efforts to treat those patients. So I would like to begin our discussion today with the treatment goals in narcolepsy and obstructive sleep apnea. Yves, can you share this with our audience?
Yes, for sure. Thanks, Rick. The treatment goals to treat EDS, especially narcolepsy and others, need to be the first key target because it is a really burning symptom that may change the quality of life of this two population. But we need also to think a little bit more larger and not just to treat daytime sleepiness, but to control other symptoms associated within narcolepsy or within OSAS. And for narcolepsy, especially, we need to control also cataplexy, sleep paralysis, hallucination. In both conditions, OSAS and narcolepsy, we need to improve disturbed nighttime sleep, being often very disturbed in these two conditions. Fatigue and brain fog are also really problematic in most of patients with narcolepsy or OSAS. And they are all affected with psychosocial dysfunction and bad quality of life. And this is a target we need to focus on. And the final goal is to standardize the follow-up and to optimize the benefit-risk ratio with the different drugs we will provide.
Yeah, thank you. I like your discussion about personalizing care of, each patient has their own set of symptoms. And of course, sleepy individuals not only are sleepy, but they're tired and they have problems with executive function, thinking, memory, focus, mood, productivity, fatigue-related accidents. So each of those bother patients in a different way. And of course, we approach the patients behaviorally, but obviously we have multiple new medications available to us, and we can achieve some of our goals through pharmacotherapy. Can you talk to us about FDA-approved treatments for excessive sleepiness, both in obstructive apnea and in narcolepsy patients?
Yes, so we are very lucky right now to have several drugs to treat daytime sleepiness in others and narcolepsy. We do have modafinil or modafinil sodium oxybate. The new one, the low salt, is the zwave, so sodium oxybate low salt, alfietol and patolosan, with quite some different approval and for sure different mechanism of action. Modafinil and armodafinil are just for adults in narcolepsy and OSAS. And sodium oxybate and the recent one, the low salt, is for patients with narcolepsy and also in kids above 7 years old. For alfietol and pitolisant, it works in managing EDS in adults. And for alfietol, it also approved for EDS in the condition of OSAS in contrast to pitolisant.
Excellent. Can you begin to explore some of the data that actually the FDA used to approve these drugs? I mean, to demonstrate efficacy. Let's begin with modafinil or modafinil.
Yeah, so modafinil is a French drug, as you know, is known for 25 years, so it's a uh, long story. And to be short, it works compared to placebo in decreasing the Epworth sleepiness scale, being a very often primary endpoint measure, a self-report questionnaire that assesses the sleepiness of the patient complaint, and it increased the MWT, being a test to of you measure 4 times during the day the ability to fight against sleepiness. It is an objective measurement of sleepiness, and as you can see probably on this slide, there is an increase of 2.5 minutes, 3 minutes, depending on the dose, with modafinil compared to the placebo. So modafinil and oral modafinil works in the same way. The only difference is that oral modafinil is a long player action with just one intake in the morning.
Yeah, those two drugs really changed the landscape of our treatment of patients with excessive daytime sleepiness, and we appreciate the French scientists for introducing us to this drug, these drugs. What about solriamfetol in excessive sleepiness and narcolepsy and obstructive sleep apnea?
So yes, sorry, alfietol is a new player in the game, and he is really helpful with several studies has been done on randomized control trial, and to prove that it works compared to the placebo dose dependently. And also there is a one open label study for 1 year that showed that there's a maintenance of efficacy based on the complaint, this same primary endpoint, the Epworth sleepiness scale, and we do see a reduction of this scale for 5 to 7 points. And the big news is that it had persist after 1 year. They also perform a 2 weeks randomized withdrawal period at the end of the trial to prove that there is a rebound of the complaint of sleepiness if you are randomized to the placebo, and if you keep the drugs with you, there is no change. So I think it's promising.
Yeah, it's an interesting drug, and I think the data supports the idea that we're not really seeing tolerance within the limits of the study. We're not seeing tolerance and rebound and withdrawal in these individuals. And as you pointed
Yeah.
out in your previous discussion about neurobiology, its effect on norepinephrine and dopamine reuptake seems to be the mechanism of action for this monoaminergic process. But in continuing with the solriamfetol, we know patients with cataplexy tend to be sleepier. At least that's my impression, that they're sleepier than the ones without cataplexy. Does the drug work both in type 1 and type 2?
Yes, good point. We just covered the topic that it works in narcolepsy and in OSAS associated with EDS, but we also did a study confirming that it works on narcolepsy with and without cataplexy. Patients with cataplexy have mostly more severe sleepiness at baseline based on this MWT and this Epworth sleepiness scale, but the amplitude of change with solriamfetol is nice in the two conditions, with again different neurobiology in the background in terms of orexin deficiency. So yes, it works in narcolepsy with and without cataplexy, both in the same direction.
Yeah, good point. And of course, it does. We don't have any evidence that improves cataplexy, but certainly the sleepiness in these very sleepy individuals. But what has the data shown in terms of the impact of solriamfetol on quality of life and functional outcomes, workplace performance, driving? These individuals who are sleepy have problems with this.
Yeah, though there's the nice studies based on the randomized control trials on 12 weeks follow-up that showed that there is an improvement in driving performances, the functional outcome based on another endpoint scale, namely FOSC, is of interest to look especially at the ability to drive, and it is improved with the solriamfetol compared to placebo. And we were also interested in looking at the work productivity as absenteeism, presenteeism, and it seems to be well managed with solriamfetol compared to the placebo. So we may say that based on different measurement, it improves sleepiness, but it improves also what is related to sleepiness in terms of functioning to work, functioning to drive, and ability also in terms of quality of life, mostly related to familial issue. So yes, it's good in terms of global activity.
Yeah, I think the the workplace performance data is very interesting. And then we now have patolosan, another French drug. So another FDA-approved drug to treat excessive sleepiness and narcolepsy. This is a new drug. What have we learned about its efficacy?
Yes, it's a new drug in US, less new in Europe. And there are several studies, at least in two major conditions. One is narcolepsy, the other is daytime sleepiness in OSAS. And most of the results show that it works on the same endpoint again, the Epworth Sleepiness Scale. On the 12 weeks follow-up, so this 3 months as done for most of randomized controlled trial. And we do have also one study with 1 year follow-up showing that it works also with the persistence of efficacy with mounts. There is no this 2 weeks randomized period as compared to the alfietol, but the open label studies show that the persistence of efficacy is still there after 1 year.
Yeah, I know you have a lot of experience with this drug, and we also know patients with obstructive sleep apnea. A certain subgroup of those individuals are still sleepy, and you've done some research on that. Could you share those results?
So yes, so patolizon works also on daytime sleepiness in patients with OSAS in two different ways. As we discussed last time, patolizon works in increasing histamine in the brain, in blocking the receptor of the transporter of histamine at the presynaptic level. So when you give patolizon to the patient, you increase histamine in the brain. Mostly, you can increase also some other neurotransmitters, but at a lesser extent. And the results show that the patient may be improved in terms of sleepiness in two ways. One is patients that are still sleepy despite the fact that CPAP machine is well done in terms of good adherence, good compliance, and no persistence of AHI. And there is also a recent study that proved that it works also in patients who cannot cope with the CPAP machine, but they are still sleepy. They are still sleepy because of OSAS. You exclude many conditions that may explain sleepiness in OSAS, again, depression, obesity, sleep deprived, but the patient cannot cope with any management in terms of orthosis and a CPAP machine, but they are sleepy and you need to improve them, and it works. And there is no key side effect. We will discuss that later, but there is no key side effect in this population specifically. So I think it's nice also to think about these drugs for EDS in OSAS.
Yeah, I think we'll be waiting for more data on pitolisant in this indication. And I should point out, of course, it's not approved in the U.S. for the treatment of excessive sleepiness and OSA, but this is evolving science, and certainly I wanted our group to have a chance to hear that. Of course, sodium oxybate is another agent that's been widely used in excessive sleepiness and narcolepsy, and particularly cataplexy, but also disrupted nocturnal sleep and other REM dissociative symptoms and the EDS. What have we learned about its efficacy, both in children and in adults?
So yes, this is quite known for around 15 years old right now in adult. That exactly what you say. It works on cataplexy, it works on disturbed nighttime sleep, and it works on sleepiness. But recent studies has been done in kids, in randomized withdrawal period, just to minimize the exposure to placebo in the patient. And for 2 weeks, the patient are with the placebo, but for the remaining period, they are treated with sodium oxybate, and also on the long-term level, because the studies has been confirmed with an open 1 year follow-up, and we confirm exactly the same results as in adults. So a decrease of sleepiness, decrease of cataplexy, and improve of nighttime sleep. But today we discuss on sleepiness, and yes, it works on daytime sleepiness based on this Epworth Sleepiness Scale adapt for kids because it's not exactly the same level.
Yeah, this was a very humane study because maintenance of effect, you got to treat the patients and then had that 2-week withdrawal period. And So very, very interesting. Sometimes it's hard to interpret that data, the withdrawal data. Um, what about JZP-258? It's now a low salt oxybate and was recently approved in July in the US for excessive sleepiness and narcolepsy, as well as cataplexy. What do we learn from the clinical trials?
So yes, it's very new and exciting drug, not in terms of mechanism of action because it's the same as the Xarem, but it's low salt, so it's of interest in terms of risk and to limit the exposure of 1.5 grams of sodium per day for those treated with 9 grams of sodium oxybate. So the study was complex. We have no time to discuss on it, but there are 4 different groups. You can be treated with sodium oxybate when you enter in the study, treated with anticataplectic drugs, namely antidepressant or drug-free, or the combination of antidepressants and Xarem, and also stimulants. They may be also in the study if you have the same dose during the whole study. So there's different groups, and for this discussion of today, it works on sleepiness that confirm exactly what we did or already measure on using sodium oxybate. So it works on cataplexy. It's not the topic of today, and it works on daytime sleepiness in the 4 different groups I just referred to you. So it's a complex study because of the heterogeneity of the population. And again, it was a withdrawal for 2 weeks, randomized withdrawal study to confirm that the Epworth Sleepiness Scale will change if you are randomized to the placebo or to the GZP-258, named zwave for those who are not yet familiar with.
Yeah, I think your point is well taken. It's 92% less salt. And again, this was a humane study from the perspective patients were allowed to continue on their stimulants with maintenance of effect. You could adjust the dose, and then we had this 2-week randomized withdrawal period to show the improvement in sleepiness and quality of life, quite frankly, in individuals. So I would encourage those to dig into the data, and thank you for that summary. And again, thank you for this great overview of the efficacy of these agents for excessive sleepiness and narcolepsy and obstructive apnea. But we also need to talk about their side effects. Can you tell us about potential side effects in these in these drugs?
Yes, for sure. When you have some benefit with drug, you have the safety concern of interest to be known for all physicians because you cannot have benefit if you have no risk. And so you need to balance that. And for most of these drugs we discuss on, there is some side effect with anxiety, with decreased appetite, with stress, with headache, with insomnia. And so this is the major side effect. So depending on the drugs, again, and the dose and the population target, this is OSAS or narcolepsy. We cannot review everyone, but I may say that generally speaking, anxiety, decreased appetite, headache, and nervousness, insomnia may be, we need to think about it and to adapt the dose when it is mandatory to do so.
Yeah, good point. I mean, we worry about these obviously have CNS effects. And when we look at research, we look at group data and they're always outliers. So it's really important for us to follow our patients and monitor for, CNS adverse events and plus the potential effect on the sympathomimetic system. So heart rate and blood pressure, those are always tremor and anxiety. Those are always things that we keep in mind. So given the side effect profiles of these agents, are there any special considerations that healthcare providers need to keep in mind?
So yes, I think there is, in addition to the classical side effect, we need to think about specific side effect. And modafinil is often the first treatment, first line therapy we propose to treat EDS in those population. And we really need to be cautious about young female because of hormonal contraceptive agent, and there is an interaction between modafinil or modafinil and this contraceptive agent that is a specific concern for modafinil. For alfietol, I think that we need also to think about the blood pressure monitoring And sometimes you need to go a little bit further with ambulatory blood pressure monitoring to be sure that there is no high blood pressure because of the drugs. It's almost the same with modafinil, but solriamfetol is a new one in the field, so we need to target that more closely. For patolosan, I think that there is less side effect in terms of the risk part of blood pressure, and hormonal contraceptive issue seems to be less problematic than modafinil, but is not 100% clear so far. And for sodium oxybate, I think we need to have this risk for high sodium formulation that had too much salt on daily basis. But of interest, we need to think about the decrease in body mass index, and it could be a big concern in kids, half of them, and in adults, one third of them in patients with narcolepsy. So to decrease body mass index could be finally a good side effect. And with the 258, the problem of sodium will be for sure no more there because there is 92% decrease.
Excellent. So, treatment selection can really be a challenge for clinicians managing excessive sleepiness. So, you've discussed efficacy data and safety data, the pharmacotherapies. Based on your clinical experience, are there any special consideration? I know this is soft, but are there special considerations that you have in terms of personalizing therapy?
Yes, thanks for this very important question about the personalized medication. There is a lot of drugs right now, at least 6 drugs on the market, and for which patient do we need to use which drug? So it's almost impossible to really answer this important question because there is no head-to-head comparison studies except modafinil and pitolisant in one studied in narcolepsy. So it's mostly based on experience in the field. And what we have in mind, especially my lab, that we make a consensus at the French level to try to propose the first step, second step, and third line therapy for the treating EDS in narcolepsy. And in favor of modafinil, we have in mind that patients need to be with severe EDS and mild cataplexy because it's not really effective on cataplexy, as you know, and low cardiovascular risk profile. For pitolisant, there is no risk in terms of cardiovascular problems, so it could be proposed in this specific population. But this is the point. And for cataplexy is in between and sometimes unclear. So patient with severe cataplexy is probably not the good target to go there. With solriamfetol, it's quite new, so it's hard to really make some recommendation, but it seems to be very active on daytime sleepiness, but not on cataplexy, and with some concern about blood pressure. For sodium oxybate, we know quite that well. So for severe cataplexy is lovely, but it's sometimes not enough for severe daytime sleepiness. It may be just for moderate daytime sleepiness, and be cautious also about the blood pressure. And for obese patient could be nice because of side effect in decreasing BMI. For methylphenidate could be nice because of this problem of contraception for young females, and this seems to be a very effective drugs to treat severe daytime sleepiness. And for the 258, it's almost the same indication of sodium oxybate, and especially for those with comorbid cardiovascular disease because of this daily salt decrease.
Yeah, certainly. And to reemphasize, one, patolosan in the US is not scheduled. So they have very low abuse potential. So ramphitol is a Schedule 4 drug, is renally excreted and does not appear to have any interaction with oral contraceptives either. So that's a potential advantage in that situation. With the methylphenidate, we always worry about tolerance and rebound and withdrawal in patients. So and then we have special populations. We have children, we have elderly patients, pregnancy. Do you have any specific considerations or that are important in terms of treatment selection in some of these subpopulations?
Yes, it is exactly what we need to go in the next 5 or 10 years. I don't know, but for which drug for which population. So I try to sum up very briefly and probably too briefly about the comorbid condition in terms of the background severity of EDS or cataplexy, disturbed nighttime sleep, comorbidity in terms of BMI, psychiatric problem, and cardiovascular problem. But we may also discuss about kids, about elderly, about pregnancy, about anesthesiology, which kind of drug do you need to propose in this specific population. And also, especially for refractory patient, we do see more and more in tertiary university hospital, the more severe patient, and they cannot be managed with one drugs, and you need to combine drugs, and you need to probably to combine drug with different mechanism of action, because if you go with just one mechanism of action, it cannot be enough. And the long-term management is also a big concern, because you cannot speculate the efficacy after 5 years when you have no data. And the randomized control trial show up often good efficacy even after 1 year. But what about 10 years, 20 years? And the long-term management need to be really answered, and it is not done today.
Yeah, I think I'm impressed with the European follow-up in patients to give us some insights in that. Quite frankly, long-term utilization, particularly some of the data that's been presented on long-term use of patolosan and polypharmacy. So I think that's been very helpful for us in terms of managing these patients long-term. So Yves, thank you for providing us with a great overview of the latest clinical evidence on the safety and efficacy of current and novel therapies for EDS and narcolepsy or obstructive sleep apnea. Now, let's close with our SMART goals, that is, specific, measurable, attainable, relevant, and timely goals. Yves, what do we hope the healthcare practitioners listening today will take away from this podcast?
So yes, thanks, Rick. I will sum up with four goals. The first is to develop personalized, effective strategy to reduce daytime sleepiness in patients with OSAS and narcolepsy. We need to consider the comorbidities we discussed, that depression, obesity, cardiovascular disorder, to make a good selection of which drugs as a first choice, second choice. We need to think, especially with those with cardiovascular problem, hypertension, or even more cardiovascular disorder, to use a low sodium oxybate, and that include a safer drugs on the daily practice. And the main last important point is to standardize and personalize the follow-up to really be sure of the efficacy with nice tools. We discuss on April sleepiness scale, but I think it's nice to discuss also on the narcolepsy severity scale, because it's covered not just the daytime sleepiness problem, but also cataplexy, hallucination, and disturbed nighttime sleep. It is for the benefit aspect, but for the safety aspect, you need to see the patient on the at least twice a year, and to look for depression, the BMI, the blood pressure, and to be sure that the benefit risk ratio is always good enough to continue the medication, or to think about changing, because we have several players right now that may help to treat the patient on the long-term level.
Yeah, excellent, Yves. I can't thank you enough for sharing your scientific knowledge and, more importantly, your learned experience with us. To receive CME or CE credit for this activity, click on the link identified here to complete the post-test and evaluation online. And also, please visit the Sleep Disorders Hub at cmeoutfitters.com, Sleep Disorders Hub, for additional educational activities, resources, and tools to improve the care of patients with excessive daytime sleepiness. Thank you for joining us today for episode 3 of our 4-part CME OCAS series. To view additional episodes on an overview of EDS and the burden it imposes, matching treatment choice to the pathophysiology of sleep, and diagnosing and treating pediatric narcolepsy with cataplexy, please visit cmeoutfitters.com. Thank you again for participating, and thank you for providing the best care for your patients. And a special thanks to Yves for his expertise and sharing his knowledge. Thank you very much.
Thanks.